Right. I have to talk about refractive errors in children and when to prescribe and manage in amblyopia. I think you have already heard about the refractive errors, so I don't have to go ahead with that, I think, right? Uh, just refractive errors or ametropia is the most common eye problem found in children, even as well as in adults, right? So usually it is considered as a minor eye related issue. Is it the case in children? Definitely no, right? So I just want to touch, maybe I don't know whether she has discussed this bit, right? Emetropia or normal vision, right? I'm talking about the children. You know that when you born as a child, every child is usually hypermetropic unless they have a congenital myopia or something refractive error, right? Usually every children are having a hypermetropic refractive error that is normal, and so with growth, bulk of emetropization is happening during the first 6 years, and usually they become emetropic by the age of 6 years, but it can start from 3 to 6 years, right? So emetropia means you don't have a refractive error plano, right? And you will have the normal vision 6. Usually they reach to normal vision between 3 to 6 years, right? By the age of at least 5-6 you have to have 6 vision unless you have a refractive errors or any other eye pathology, right? So refractive errors means that the failure of this normal visual development or achieving the emetropia, right? That proper during proper age. So that's that optics, you know, that I don't have to say, right? So refractive errors. So that is the mismatch between the length of the eyeball and the refractive power. So when you have a matching correlation between those two, you will have the emetropia. But when you don't have a proper correlation or mismatch, you will get that refractive error. So usually so in emetropia, parallel light rays, when there's no accommodation, it will fall onto the retina, making the image. That is the emetropia. So when you don't have that, when you have a refractive error, so that will not fall onto the retina, non-accommodative stage, right? So then type of refractive errors must have discussed, right? So I don't have to discuss. So then mainly myopia, hypermetropia or hyperopia, right? And then the astigmatism, right? So I'm not going to details as she has gone through, so then my life easy, right? So astigmatism can be associated with myopia and hypermetropia, and then you will get usually myopic astigmatism, hyperopic astigmatism. Mostly you get a combination, right? So other thing is not related to children unless they have undergone cataract surgery, right? Okay. So why is managing refractive errors more important in children? So that is because uncorrected ametropia or anisometropia can lead to amblyopia, which is irreversible after passing a certain age. So that is the most important thing, not like adults, right? So then that can perform poor visual acuity, the poor school performance and other social activities and all those things matters, right? It is a major issue in children, right? So how do you diagnose? I think that part you must have done, right? So in children, this is a occurring refractive error for any person we can't prevent, right? So that is dimensions of the eyeball which lead to refractive errors, right? But it is important to detect early in children to prevent amblyopia. That's the most important thing, right? So then diagnosis is that part examination, right? I don't have to go into detail, right? You must have done, right? Not done, right? Okay. So then basically like one thing is for kids, definitely they will not come and tell you that they can't see unless they are grown up. So that is very important, the screening for the vision at proper age, right? So at the moment currently in Sri Lanka, you know that SMI is happening at grade 1 and 4 and 5 or 6 or somewhere, right? So then usually, as I said earlier, children get their normal visual acuity by the age of 4 to 5 years of age. So actually that is the ideal age for the first screening, right? So if you are emmetropic and if you have normal vision, so then that's all right. Then usually they will get with a grown age, then myopia or any other that errors can come, right? So then that is the first like in this developed countries, actually first vision screening for kids are doing in the upper kindergarten, that age is 4 to 5 years. But in our setup currently it is SMI is doing at the grade 1. Actually when our children, when they go to grade 1, they are almost finished 5 years and almost 6 years, and sometimes when they do this SMI they are almost close to 7 years. So in my opinion, I feel that is little late, right? I will let you know later why, right? So then that is the first thing. And otherwise if they are complaining like symptoms, right? So symptoms like maybe like squinting or go close to see things, or maybe poor school performance, like those symptoms you can. So then what you have to diagnose, that's first you have to check the uncorrected visual acuity and maybe pinhole, and then you have to exclude any extra intraocular other pathologies for the impaired visual acuity, and you do the refraction, right? So refraction in children, all the children you can do dry refraction and subjective, but quite a young one you may do cycloplegic refraction, because otherwise they will accommodating and you might not get proper refractive errors, will not identify. So that's the thing. So when you come to the management in refractive errors in children, so what is the importance? There's a one key thing, that is the visual maturation or visual development age. So children are completing their visual maturation by the age of 7 to 8 years or maximum 9 years. So during this period, if they have a refractive error, if you don't correct, they will lead into amblyopia permanently. Once you pass the visual maturation age, the vision improvement is hardly any or very minimal, right? So this is the most important thing, managing refractive errors in children, right? But still in our society, majority of people are not aware of this, right? So usually this now if you are doing this SMI, other than that most of the parents are not aware that you need to check vision in children, right? So that is something, because once within that small window period only you have to correct this thing if you want to prevent the amblyopia. So so the visual like refractive error correction is optical correction, usually with spectacles for children, but all the children you can consider contact lenses, or sometimes we use both, right? So that is the main thing, and you know how to correct, right? So you must have touched that, right? I don't have to. So then myopia with concave lenses, and hyperopia convex lenses, and astigmatism spherocylinders, right? Then this is the question, when to prescribe optical correction to children? Are you prescribing each and every error for children? No, that depends on the age and the type of the refractive error and the amount of the refractive error. So that's totally depend on that. We are not prescribing each and every error for children, right? So that is that. So I will I have categorized into two categories, that is preverbal children, that is less than 3 years, and older children, right? So this is the American Academy of Pediatric Ophthalmologists guideline, right? So usually isometropia means both eyes you have the same refractive error, right? And anisometropia, you know that there's a difference, right? So usually this is the chart, like less than 1 year myopia is, if it is more than -5 only we correct. Why? Then smaller myopic errors we are not correcting in smaller children. Why do you think? Anybody can give an answer? Why? Because their working distance is shorter. They don't see far, right? When they are small, their working area is very short. So then it's all right? That is the reason. But if it is more than 5, you have to correct, right? For less than 1 year children. So if it is 1 to 2 years, maybe more than -4. But 2 to 3 years, more than -3, right? So that is that. And hypermetropia or hyperopia, if there's no esotropia, usually as I said, like if it is more than 6 plus only we correct. But if you have a convergence squint, even smaller plus correction you might give, because that will help to reduce the esotropia, right? So and 1 to 2 plus up to +5 we don't correct, right? And 2 to 3 years of age, if it is more than 4.5 diopters we correct, right? So if there's a esotropia, so you can see the like our threshold is lower, so right, better to correct with the even minimal plus if you have a esotropia. And astigmatism, usually less than 1 year up to 3 you don't correct, unless if there's if you can check the visual acuity, and if there's no if you don't have any visual deprivation or any difference between both eyes visual acuities, you don't correct it up to -3 cylinders, right? And 1 to 2 years up to if it is more than 2.5 years, but 2 to 3 years more than 2 you correct, right? So when you have anisometropia, so that's also like if the difference is more than 2.5 -2.5 in less than 1 year, you correct it because it's embryogenic, that, right? The same for the 1 to 2 years. But if it is 2 to 2 years, if there's a difference more than 2, you correct, right? For the hypermetropia, it is plus 2.5 difference less than 1 year you may correct, right? And 1 to 2 years plus 2, and above 2 plus 1.5, or even you know that it is plus 1 diopter difference is embryogenic, right? For the older children you have to correct. And astigmatism also, like if there's a difference more than 2.5 in less than 1 year you may correct, or if it is 1 to 2 years, like difference is if more than -2 cylinders you correct, right? So that's how usually guidelines, because only thing is when you like every station, every institute, you may not be able to check the visual acuity in less than 3-year-olds, right? Sometimes you may have to go straight away with the cycloplegic refraction. So then this is like this is the guideline, like if you see like the corrections, if it is very significant only you can correct. But how do you check visual acuity less than 3 years? Anybody? Can we check? Yes or no? No? How do you check? We don't know. Right? One person can tell. I can't hear anything. KP Cardiff, right? So it is not available everywhere sometimes, right? Then you have to simply go ahead with the CPR, right? So then that's how you have to decide, right? All the children. So all the children anyway above 3 years, now you may know that. So for what is the normal vision for a 3-year-old? We take it up to 6/9 Snellen acuity, take it as normal for that age, right? But some children even by 3 years they reach 6/6 with maybe K pictures, right? So then usually majority of the children 4 to 5 years.
Some useful points, read and select your lens, know about what is going to take your energy, what should be the lens, what is the laser magnification stuff. Those are basic stuff for you. And if you are coming for exam,
Things if you have, even sometimes small errors you might consider correcting if you are symptomatic, right? But
some useful points, read and select your lens, know about what is going to take your energy, what should be the lens, what is the laser magnification stuff. Those are basic stuff for you. And if you are coming for exam,
better, like if I am like in my practice, what I do if I feel that is not appropriate, like I usually do a CPR and do a PMT and see. Sometimes you may not see those, and so you have to consider, because sometimes they may have 6 minus 6/9 vision and may show small errors. Sometimes you prescribe, right? Because most of the time we are not doing the refraction, right? So then sometimes they come in a few months time, you don't have error. So then if it is symptomatic, yes, you can give. But if the child is not symptomatic, I usually recheck in few months time, because one thing, spectacles are costly, right? You ask them to buy something which is not relevant, and in a few months time you have to tell, no, you don't have anything. So then you have to think twice, like when you are prescribing, if they are not symptomatic and with the minor errors, right? The practical point of view, best thing is to reassess in few months time, maybe 6 months, right? If they are not symptomatic, right? The most important thing, managing refractive errors in children. Most of the outcome depend on this, the counseling, right? Not like adults, you give the glasses, you ask to wear, come back, because there's no issue, because if they have normal visual development, you will get full vision unless you have some pathology, right? So for kids that's not the case, right? Especially during this visual maturation age. So the understanding of the gravity and importance of compliance is very important. It should be by parents, because we can't explain anything to children. They are small and they will not understand. When they realize how important it is, time has passed. So in pediatric practice, this is the most important thing. You may not take only few minutes to see the child, but you need to have spent more in this part, right? Because totally outcome will depend on the parental understanding or guardian's understanding. Because otherwise they will not bother that you say this මේ කන්නඩිය දාන්න එන්න මාස 6න් මාස 3න්, they will just go and come, right? Then when you dig it, they are not wearing. So it is very, very important, this part, my point of view, right? Because usually when they are between visual maturation age, it's constant usage of spectacles is very important, except during sleeping and bathing. So that we have to stress them and tell that, right? So that's something very important, because sometimes when little bit children, when they realize that they can see better through the glasses, they start using. Sometimes when they are very small, till they realize that, it's very difficult. Sometimes that is the real critical part. When they realizing that is important, maybe their time has passed, right? So that is the most important thing. Anything else you want to know up to this point? Anything you want to ask? No? Okay. I can proceed, right? So then management of amblyopia. I don't know whether anybody done about amblyopia, because I am here talking about only the ametropic and anisometropic amblyopia management. But amblyopia, you know that by definition it's like reduction of best corrected visual acuity, one eye or both eyes, two lines difference, there's no attributable structural abnormality, right? So then there are types like ametropic or anisometropic amblyopia, that is related to refractive errors, uncorrected refractive errors. And then other one is strabismic amblyopia, and my part is missing, sorry, otherwise deprivational amblyopia, right? Right? Then strabismic means amblyopia due to the primary cause is strabismus, right? So then deprivational, it can be so your sensory deprivation due to some media opacities or any other ocular pathology. So those are the things, right? So whatever the management of amblyopia, basic principle is, first thing is the correcting the underlying cause. So underlying cause may be ametropia, anisometropia or strabismus. So some sensory deprivation due to certain correctable causes, right? So that is the first thing. Like if it is refractive error, you have to correct refractive error. Sometimes when it is come to strabismic amblyopia, it is bit different, right? You may have heard sometimes even though it's purely simply due to the amblyopia is due to the strabismus, but sometimes we may do a amblyopia management before correction of strabismus. That is the, you may be like, that is the teaching, right? Is that? No, we don't know, right? Is that the usual teaching? But you can't practice it for everybody in that way, because sometimes the amblyopia is solely due to strabismus and there's no refractive error. So you are doing patching. Sometimes they are not doing the patching properly, and one point you may have to correct that and then do that. That is something practical. You have to individually decide, right? So I won't say that always correct the amblyopia and correct the strabismus, but general teaching is that, but that you can't do practically all the time, because no point you are doing patching and they are not doing properly. Amblyopia is due to the deviation, and then they are passing the visual maturation age, and after that you can't do anything, right? So then by that time sometimes we may have to consider whether to you correct it and continue the amblyopia treatment. So then if you are going ahead with that kind of things, you have to counsel the parents properly and you have to do, right? Because in my practically I have experienced there are certain cases like there's improvement, because you do patching but no improvement. Sometimes you correct it, because when you correct its eye is straight, right? So then you have to tell that if you don't do the patching and if there's a dense amblyopia, then it might reverse or go into the other way, right? But it's something you have to assess it individually, right? So that part. And then if it is like sensory deprivation, you have to, if it is cataract, you have to correct that. If there's any other like corneal opacities or something, but whatever the pathology where you can correct, you have to do that. And then you come the other part of the management of amblyopia, that is the penalization of the sound eye. How do you can penalize? So what is the basics of that? Why are we penalizing the sound eye? Why are we doing that? Because what will happen when children, when they see through both eyes, if there's a difference in both eyes, so when you have a sound vision, you see clear, and the other eye you see blurred or impaired vision. So then brain has to ultimately put those things together. So then what will happen? Brain can't put together, they are two different things, right? They are in the visual maturation age. What will brain do? They focus only with the sound eye and neglect other eye. In lay term, you call it lazy eye or amblyopia. So that is the thing. So then this is the basic of penalization, the sound eye. So then what you are doing, you penalize or patch or maybe atropine penalization you do, and then you are forcing brain to, the practical point of view I'm telling, forcing the brain to see through that eye. So that is the basic understanding to improve the vision, right? So if you are doing that properly, actually It's very successful, right? So how are you doing occlusion? Then, so penalization can be done in occlusion of sound eye or atropine penalization, that is medical penalization, right? So so how are you deciding what amount, how long doing the occlusion? Anybody want to answer? No, only want to listen. How are you? You know that pedic study, right? I didn't take that. So there's a study and pedic study that has shown that earlier good old days used to sometimes full day occlusion, right? So but this study we have found that evidence are there. We can cater depending on the severity of amblyopia or either age of the child, right? So then depending on the, how do you categorize amblyopia severity? Mild, moderate, dense or severe? You know how? Less than like 612 mild, between 612 to 624 moderate, more than that dense, right? So according to that study, we usually mild amblyopia we can just effective as 6 hours occlusion, 2 hours, right? So that is, then earlier it used to like close 6 hours or full time, like now no need. If it is a mild amblyopia you can start with 2 hours, and then if it is a moderate 3 to 4 hours, right? And if it is dense amblyopia, maximum 6 hours, right? So in then patching, when you are, if you are starting amblyopia, you have to stress them, the parents, that you have to patch the eye, not the spectacles, right? This is something very important. Sometimes they patch your spectacle and come, right? So because no point patching the spectacles, then they will see up or down, right? Another thing is usually when they are patching, especially if it is a dense amblyopia, there should be a like parental supervision during the patching, because nobody will like to see through a poor eye with poor visual acuity. So if the parents, and if you have asked to occlude 6 hours, and then when you review again, wahanawada? Oh, wahanawa, right? If you ask, oh, පැය 6ක් වහන්න කිව්වනේ. වහනවා, right? So you have to dig and ask. If you ask properly, nothing happening. හොඳට question කරලා නෑ වහගෙන ඉන්න නම් කැමති නැහැ. හරි අමාරුයි. පැය භාගයක් විතර තමයි ඉන්නේ. ඊට පස්සේ නම් ඉන්නේ නැහැ. වැහුවාම ගිහින් නිදිය ගන්නවා. This is that the story, right? So it is very important to take your time and explain them how important this is. So if they are doing it properly, actually it is improving, right? So if the visual acuity equal in both eyes, how do you stop occlusion? These are practical things you all are doing, right? How are you all doing? We don't manage children in eye hospital, right? Is that right? How do you do? Anybody? Have you heard that you have to tail it off? During the visual maturation age, you don't abruptly stop that, produce, and over a period of time, tail it off, right? Otherwise, it will reverse again, right? So then when do you use the atropine penalization? What's the percentage of atropine you are using? Are you all module 1, module 2, module 3, module 4? Which level are? We are not talking. No answers. Right? Yeah, it should be interactive, no? Otherwise, it's like really boring. Not somebody talking, and you are listening and going, right? 1%, right? 1%, once a week or twice a week, right? So, what do you expect from that with atropine penalization? You blur the eye, right? Sound eye you blur. Then you have to, then that blurring should be actually the worse than the, once you blur the vision, should be lower than the amblyopic eye, right? Otherwise it will not effective, right? So maybe for a moderate to mild amblyopia would be all right, but when it is a dense amblyopia, of course bit of a question, because if your blurring is even, then still the better vision is in that eye, there won't be any like effect, right? So that's something practical point of view, right? So anything else? I think I'm towards then. Anything else you want to know? Can we prevent amblyopia? The simple thing is screening. So screening at the correct age, that's the most important thing, right? So that's why, like ideally in developed countries, that's we do it 4 to 5 years of age, actually upper kindergarten. So my point of view, I think that's should be the way, because when you diagnose it around 6 years or let's say closer to 7 years, maybe you have a very small window period to manage. If there's a significant refractive error with dense amblyopia, it may be a bit difficult to manage, right? And one more thing I just want, what's the age limit of managing amblyopia? Is there an age limit? So you, yes, okay, during visual maturation age, if you get amblyopia, yes, you try. If a child comes with at 11 years, 12 years with amblyopia, what will you do? What will you all do? So there's amblyopia. So what will you all do? Answer, will you all? I'm getting really bored, right? You are not doing anything. You are already amblyopic. Put your glasses and go, right? So according to the SPEDIG study, even late presentation, you can try amblyopia, even a grown-up children, right? So you can do a trial of occlusion and see, right? So don't give up. Usually now it's not that, right? But and the other point what I want to tell now, you are doing occlusion for many years. Vision is not improving. Now child is around 9, 10. What will you do? Are you still continuing? No, that's the point where you have to stop. Because if you have done it properly, during your visual maturation age, if you have done properly, by the age of around 8, 9, you should have the good vision. They have not done, and for many years you are doing, you are telling them to do, they are coming and telling we are doing, but actually nothing happening. So that is the point where you have to stop, right? But a new patient with a newly diagnosed, even a grown-up child, you can try, right? So is that the way practicing? No, don't know. Right? So this is my just take home message, right? Anything else? Atropine penalization, wherever you are reaching to your maximum vision. That is the thing, right? So ultimate goal is in amblyopia treatment, achieve the maximum vision, right? Or equal visual acuities in both eyes. So that is that. For the patching or whatever the amblyopia treatment is that. But when you are doing it and for many years and it is not practical and they are not doing, then don't do. Sometimes I come across clinic patients like now 14 years, 15 years, maybe they have undergone surgeries and all those things, and amblyopia, you are asking to patch 6 hours and they are coming and telling, no, now for many 7, 8 years you are doing, no point. Then you are just a hassle only, right? You are also lying, they are also lying, and only a hassle to child, right? So that's the point where you have to stop those things, right? Then you have to explain them, look after the other eye. That's the most important thing, right? Right. Anything else? I hope covered your topic. Thank you. Right. Thank you.